welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
For our very first journal club for July, we're going to have Sarah Sindelar, who is the PGY2 critical care pharmacy resident at Nebraska Medicine. And today she's going to be presenting on the optimal timing of resumption of anticoagulation after intracranial hemorrhage in patients with mechanical heart valves.
So first off, I have no financial relationships to disclose. Bleeding is a common complication of oral anticoagulation therapy. Anticoagulation is held to promote intracranial hemorrhage stability after a patient has experienced intracranial hemorrhage to prevent hematoma expansion in the acute phase. Patients who have mechanical heart valves require long-term anticoagulation with their vitamin K antagonists to reduce their risks of thrombotic events. However, anticoagulation-related intracranial hemorrhage is often reversed and held to prevent that hematoma expansion. It's important to note that you should balance the risks of thromboembolism and recurrence of intracranial hemorrhage in these patients as well, just to look at if you're going to resume their anticoagulation or not. And however, there is limited evidence available about optimal timing of anticoagulation resumption in the high-risk period after a patient has had an acute intracranial hemorrhage. For epidemiology with our patients with mechanical heart valves, they do have those thrombotic complications of valve thrombosis, ischemic stroke, and systemic VTE. For these patients with mechanical heart valves, their risks of thromboembolism when treated with anticoagulation is reduced to 1 to 2% per year. However, their risks of intracranial hemorrhage when treated with anticoagulation is about 0.5% per year. However, on the flip side, their risk of thromboembolism without anticoagulation is approximately 22%. Based on the etiology of intracranial hemorrhage, it can be classified as either spontaneous or secondary intracranial hemorrhage. Spontaneous intracranial hemorrhage is mainly associated with small vessel disease resulting from systemic disorders that affect the brain. Patients who have chronic hypertension may experience elevated pressure that can cause chronic damage and weakening of their small vessels in the deep brain regions. The other etiology is cerebral amyloid angiopathy, where amyloid proteins build up in the walls of the blood vessels, leading to fragile blood vessels that are more prone to bleeding. However, our secondary or traumatic intracranial hemorrhages make up approximately 15 to 20% of intracranial hemorrhages, and this can result from a trauma, a rupture of an arterial venous malformation or fistula, coagulopathy, vasculitis, hemorrhagic conversion of ischemic stroke, neoplasm or tumor, and one of the most common reasons is if the patient is on anticoagulants or antiplatelet agents. Based on the site of bleeding, intracranial hemorrhage can be broken down into epidural hemorrhage, subarachnoid hemorrhage, subdural hemorrhage, or intracerebral hemorrhage, or intraventricular hemorrhage. The primary focus of this journal club will be with the intracerebral hemorrhage or within the brain parenchyma itself. However, the site of bleeding can be isolated or they may coexist in a single patient. Neuroimaging can further distinguish brain parenchymal hemorrhage into two specific types. We have our lobar hemorrhage, which involves the cortical and cortico-subcortical structures located in the frontal, parietal, temporal, or occipital lobes. However, intracranial hemorrhage can be defined as deep when it has basal ganglia involvement, internal capsule, involves the cerebellum, or if there is any brainstem involvement. Previous literature to the study, there was a multi-center retrospective observational cohort study that was completed in 2018. They did have 137 patients with mechanical heart valves that had anticoagulation-associated intracranial hemorrhage. They looked at therapeutic anticoagulation versus no anticoagulation. For their outcomes, they saw an increased risk of hemorrhagic and thromboembolic outcomes when they restarted anticoagulation less than 6 days after intracranial hemorrhage. However, they also saw that there was a significant risk of hemorrhagic complications when they resumed anticoagulation after an intracranial hemorrhage, which within 13 days. So for their authors' conclusions, they said that therapeutic anticoagulation should be withheld for 2 weeks after intracranial hemorrhage in patients with mechanical heart valves, and at a minimum of 6 days for patients at high thromboembolic risk. However, the study did note that there was a limited sample size and there was a short duration of follow-up in these patients. There is a standardized tool that can be utilized for patients to look at their neurologic disabilities, and this comes from the American Heart Association with the modified Rankin scale on a scale of 0, where the patient has no symptoms, to a scale of 6, where the patients have died. The scale is utilized in a lot of looking at neurological disabilities worldwide, and is just a nice standardized tool that can be utilized to assess a patient's risk of neurologic disability after an intracranial hemorrhage. There also is an intracranial hemorrhage score, which is a simple grading score that allows for risk stratification on presentation with intracranial hemorrhage. And this was created to improve standardization of clinical treatment protocols and clinical research studies in intracranial hemorrhage. Each factor was found to be an independent predictor of 30-day mortality, which increased steadily with an increase in intracranial hemorrhage score. Intrafrontal origin strokes affect the brainstem and cerebellum, and these are important for autonomic functions, including breathing, heart rate, body temperature regulation. So if this is involved, the patient has an increased risk of mortality. In the study that validated this score, no patients in the study had a score of 6, but they did extrapolate and estimate that the 30-day mortality is 100%. Our 2015 guideline recommendations for whether to resume anticoagulation after intracranial hemorrhage has 2B recommendations for both statements. They say if a patient has a non-lobar ICH, anticoagulation might be considered, especially if there are strong indications for these agents. However, they say that you should avoid oral anticoagulation for at least 4 weeks in patients without mechanical heart valves, because this might decrease the risk of ICH recurrence. However, there was also a 2022 guideline update where they stated that patients who have mechanical heart valves or LVADs that put them at a high risk of thromboembolic events, they should have early resumption of anticoagulation, which is reasonable. However, in patients with atrial fibrillation, they recommend initiation of anticoagulation approximately 7 to 8 weeks after intracranial hemorrhage. They do have a statement that states that the decision to resume anticoagulation, for example, at 14 days or potentially earlier for patients with mechanical heart valves and relatively small intracranial hemorrhage, is reasonable and safe in these patients. However, they should be individually assessed. Which leads us to the article that was published in 2024, where the investigators looked at resuming anticoagulation after intracranial hemorrhage in patients with mechanical heart valves. The objective of the study was to evaluate the association of timing of anticoagulation resumption and look at the risks of thromboembolic events, including acute ischemic stroke, the patient had a new intracranial hemorrhage, or they had hemorrhagic expansion from the initial intracranial hemorrhage, or if they had any intracardiac thrombosis within 30 days of intracranial hemorrhage. This was a multi-center retrospective cohort study completed in 2 hospitals in Massachusetts. For enrollment, they looked at a partners research patient data registry to identify patients who had a mechanical heart valve and had a diagnosis of traumatic or spontaneous intracranial hemorrhage. This was a centralized database containing electronic health record information for patients within those 2 health systems. And patients were identified using discharge summary notes for mechanical heart valves, or ICD-9 and ICD-10 codes for traumatic and non-traumatic intracranial hemorrhage. The study included adults who were at least 18 years of age. They had to have a mechanical heart valve, and they needed to be hospitalized with an acute traumatic or spontaneous intracranial hemorrhage. They excluded patients with an unknown status of anticoagulation or patients who died or were designated with the status of comfort measures only, or CMO, within 48 hours of their intracranial hemorrhage. And the patients who were included were followed for 30 days after their intracranial hemorrhage hospital presentation date to evaluate for the occurrence of the outcome measures of interest. For the study's specific anticoagulation resumption timing, they looked at their exposure of interest was looking at the timing of reinitiation of therapeutic anticoagulation, if at all resumed. Medication administration and provider notes were reviewed to determine the initiation of therapeutic anticoagulation. For early resumption, they said it was reinitiation of less than 7 days. Late resumption was at least 7 days, but less than 30 days after intracranial hemorrhage. And the authors stated that they assumed the patient had no resumption if it was resumed 30 days after intracranial hemorrhage, or if the patients had no anticoagulation resumed. However, for their covariates or may affect the results of their study, they had no standardized heparin protocol that was available for titrations based on PTT results. Patients were initiated on intravenous heparin infusions plus or minus warfarin, which was used. They wanted to standardize it across various profiles of different anticoagulations for the purpose of this study. However, it was up to the providers to determine dose changes and as-needed heparin bolus doses if needed. So in this study, there was a wide variation in time to therapeutic PTT that may exist, and this may affect the patients on continuous heparin as monotherapy or are being bridged to warfarin. The primary outcome was looking at the composite of symptomatic hematoma expansion or new intracranial hemorrhage, acute ischemic stroke, and intracardiac thrombus within 30 days of intracranial hemorrhage. Their secondary outcomes were the individual outcomes of the composite primary outcome itself. And the occurrence of these outcomes was based on review of clinical documentation and available repeat CT and MRI scans. For their definition of acute ischemic stroke, they stated it was an occurrence of a new neurological deficit diagnosed by the clinician with an associated acute infarct found on CT or MRI. And they stated that a symptomatic intracranial hemorrhage was if they had hemorrhage volume expansion or a new intracranial hemorrhage that was remote from the initial presenting hemorrhage itself. They had 3 groups where they broke them down into early resumption, late resumption, and no resumption. For their statistical tests, they did a univariate analyses with an ANOVA test to compare the 3 groups. In addition, they did use a chi-square test to look at the differences in the patients who had early resumption versus late resumption of their anticoagulation. And they used a Cox proportional hazards model to look at the association between when a patient had their anticoagulation resumed and the time to where they had an outcome of interest. And then they also used Kaplan-Meier curves to depict the time to event association as well. For the patient cohorts from the data registry, they captured 290 patients and they found 195 patients who had an intracranial hemorrhage. 11 of those patients were excluded, where patients either died within 24 hours or they transitioned to comfort measures only status, or there was an unknown time of anticoagulation resumption, which left the investigators with 184 patients total, where they were broken up into early resumption, late resumption, and no resumption groups. Baseline demographics and clinical characteristics were collected to characterize factors that may increase the risk of thromboembolic or hemorrhagic events. The median age was approximately 65 years, where the no resumption had a median age of 75 years. Approximately 63% of the overall cohort were male, and approximately half of the patients had concomitant atrial fibrillation at baseline. And looking at these patients who had anticoagulation resumed early were more likely to have a diagnosis of atrial fibrillation. An aortic valve was the most common location of mechanical valve replacement, followed by mitral valve. Patients had a median GCS score on presentation of 15. However, patients who did not have anticoagulation resumed were more likely to present with a lower GCS score. A majority of the patients were taking warfarin therapy as their primary therapeutic anticoagulant, and approximately 30% of patients were taking concurrent antiplatelet therapy. Most patients had a therapeutic INR on presentation with a median INR of 3, and however, approximately 86% of patients received anticoagulation reversal. Patients who had anticoagulation resumed early were less likely to receive anticoagulation reversal, and patients who received factor replacement could either receive FFP, prothrombin complex concentrate, or PCC, or if they received recombinant factor 7 or recombinant factor 9. Subdural hemorrhage was the most common location of intracranial hemorrhage, and patients who had anticoagulation resumed were less likely to have intracerebral involvement and to have a midline shift on imaging. And no anticoagulation resumption was more likely, or patients who had a midline shift were more likely to not have their anticoagulation resumed. And approximately 45 patients of the overall cohort had a midline shift present on imaging. And approximately 67% of the patients in intracranial hemorrhage had a lobar location. The median ICH volume was 10.5 mLs. And if you remember from the ICH score, in order for patients to get a point of 1, their ICH volume needed to be greater than or equal to 30. So in these patients, their median ICH volume was a little bit lower, so they would not have as high of a risk of mortality. For their primary composite outcome of symptomatic hematoma expansion or new intracranial hemorrhage, new acute ischemic stroke, and intracardiac thrombus within 30 days of ICH, there was no difference between the groups. However, you can see that in acute ischemic stroke within 30 days, 9 of the 12 acute ischemic stroke events occurred before anticoagulation resumption, and patients who had a new intracranial hemorrhage or an ICH expansion within 30 days, 5 of the 16 events occurred before anticoagulation resumption, where 11 events occurred after anticoagulation resumption. Looking at the median time from when they were admitted for their intracranial hemorrhage to anticoagulation resumption, the mean time in the overall cohort was approximately 12.7 days with a standard deviation of 14.4 days. Patients who resumed their anticoagulation early were admitted for significantly fewer days compared to those who had a late resumption, which demonstrates that there was a significant difference in their length of stay, whether they had anticoagulation resumed early or not. Looking at discharge disposition, patients with anticoagulation resumed early were more likely to discharge home, and patients who did not have anticoagulation resumed, they had a higher incidence of in-hospital mortality, or they were more likely to discharge to hospice as well. However, there was no significant difference in these measures among patients who resumed early versus late. This was primarily only seen between patients who had no anticoagulation resumed at all. For the chi-squared of just looking at their adjusted and unadjusted hazard ratios for the time to events with just looking at patients who had early versus late anticoagulation resumption, or those who had no resumption at all, patients who did not have anticoagulation resumed were at a significantly higher rate of an acute ischemic stroke. However, there was no difference in the hazard of the composite outcome between these three groups. In our early versus late anticoagulation resumption, there was no difference in the hazard of the composite outcome or new or expanded intracranial hemorrhage or acute ischemic stroke, and that was the same for their unadjusted hazard ratio in addition to their adjusted hazard ratio, where they adjusted for age, admission, GCS, if patients had a history of atrial fibrillation, or if they had a hematoma expansion. For discussion of the article, the decision about the timing of anticoagulation resumption in patients with mechanical heart valves and intracranial hemorrhage require a careful balance between their thromboembolic risk as well as their expansion or recurrence of intracranial hemorrhage. The study did find that patients with atrial fibrillation were more likely to have earlier resumption of anticoagulation, since atrial fibrillation is a thrombotic risk factor. They did stratify their patient cohorts based on the timing. They did provide evidence demonstrating the safety of resuming anticoagulation within 7 days after intracranial hemorrhage based on the previous literature. And they also looked at the evaluations of outcomes and how they related to a patient's baseline characteristics. For limitations, there was a variability in their prescribing practices of their heparin infusions due to that lack of their standardized dosing protocol. They were unable to adjust for all confounding variables that could affect the groups. There was a little bit of selection bias in these patients, since the decision to resume anticoagulation and the timing of reinitiation or their therapeutic targets were at the discretion of the treating providers. And this study also only included a small number of patients with anticoagulation that was not resumed. For authors' conclusions in the study of patients with intracranial hemorrhage and mechanical heart valves, there was no difference in their 30-day thrombotic or hemorrhagic brain-related outcomes when anticoagulation was resumed early versus late. However, they did find that patients who did not have anticoagulation resumed within 30 days or never had their anticoagulation resumed had a higher baseline intracranial hemorrhage severity, higher in-hospital mortality, and were at an elevated risk of acute ischemic stroke within 30 days of intracranial hemorrhage admission. It is unclear if their acute ischemic stroke risk was related to their worst baseline intracranial hemorrhage severity, or if it was due to the lack of anticoagulation resumption itself. For summary, the study findings may guide optimal timing for anticoagulation resumption in our patients with mechanical heart valves. However, there are a lot of factors guiding decisions for anticoagulation resumption, including baseline characteristics, patient's medical history, if they received anticoagulation reversal, or any sites for their neurologic imaging. The study only looked at follow-up up until 30 days, which was a limitation of the previous literature, and follow-up beyond these 30 days is warranted. Since there is a lot of variability between all these studies of whether you define risk for a patient for thrombosis or if they're going to have any hemorrhagic complications, validated risk scores in clinical trials are needed to determine optimal timing of anticoagulation resumption after intracranial hemorrhage. I would like to thank my mentor, Dr. Emily Langenhan, who is our anticoagulation stewardship coordinator at Nebraska Medicine, who has helped put together this presentation. And I'm happy to take any questions from the audience if there are any.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.